Hello, everybody. Welcome back. Science Dispatch Podcast, episode 43. My name is Cameron English. I'm your host as always, joined again by the thoughtful, the insightful Dr. Chuck Dinerstein, Director of Medicine at the American Council on Science and Health. Chuck, it's been a few weeks at this point. How are you? What's going on?
I'm doing well. When you say insightful, do you spell out S-I-G-H-T or C-I-T-E?
I think because you're insightful, you can be insightful.
I just asked. Just trying to find out. Everything's good. It's, in our world, it's a Memorial Day weekend, and it's gorgeous out. It's been a fantastic spring, I have to say. It's been nice here.
It has been beautiful. And by the way, as Chuck mentioned, Memorial Day has just passed by the time you're hearing this. So happy Memorial Day to all of you out there. And hope you're spending some time with your families, barbecuing, and memorializing the important folks that we all know. Okay. So we've got two stories to discuss as usual. The first is Chuck's story. And as I mentioned off air, Chuck, I love this title. It's you doing your best philosophy professor impersonation. Which came first, the cannabis or the schizophrenia? And here we're talking about a very interesting study out of Denmark, I believe. And then we're also going to talk about Pfizer's new weight loss pill. Our good friend, Dr. Josh Bloom, has a story called, Will Pfizer's new weight loss pill silence the Ozempic commercials? Josh always, as nearing retirement age, focuses on the key question, which is how much advertising he has to watch. Okay.
I hear that. And by the way, the answer to his question is no.
That's right. That's right. You just get two commercials now instead of one irritating commercial. Okay, so let's dive into this first story, Chuck. This study got a lot of headlines. People were intrigued. And I think it's obviously because on the one end, you have the drug warriors who think that marijuana is the next greatest evil behind, I don't know, pornography or whatever other bad thing people are concerned about. And then on the other side, you have the drug liberators or the drug legalization advocates who say that pot cures glaucoma and it treats pain and it gives you wings and everything, right? So this is an interesting study because it seems that it has the potential to irritate both sides of this argument, depending on how you look at the data. So give us a quick rundown of this study and the article you wrote about it.
Okay, well, I think that the researcher has been toiling in the fields of schizophrenia and substance use disorders for several years. This is not his first paper on the topic. And he begins by pointing out that there has been a rising use of cannabis globally, in large part, as you've suggested, due to its legalization as a recreational drug. The other recreational drugs we have would be alcohol and maybe tobacco. And with its legalization, there's been a lot of commercialization of that product. And with commercialization has come the market forces that want to differentiate one product from another on the market. And the fastest way to differentiate it, besides price, is potency. So the potency of weed has gone up significantly for the boomer generation, for which I'm in. And as I say, it ain't your dad's pot anymore. The TH levels are quite high. And as a result, with those two trends in place, the author's been looking at psychiatric disorders for a similar period of time and sees a rising incidence of schizophrenia. So the study he did was to look and see whether it was possible that people with cannabis use disorder, a whole nother topic for another day, but people that were based on some criteria were addicted to cannabis also had a higher incidence of schizophrenia. And to get at that, he went to a nationwide Danish registry on all patients who were admitted to the hospital with psychiatric disorders. So it does leave out the outpatient population. And he looked specifically at a population of individuals who had both cannabis use disorder and schizophrenia. So there's some bias in the sampling. And what he found was that there was clearly a relationship between people using cannabis and developing schizophrenia. And with that, he made what I described as a great leap of faith. And what he wrote was, assuming causality, and in the article I emphasize those words, approximately 15% of recent cases of schizophrenia among males in 2021 could have been prevented in the absence of cannabis use disorder. But the key part of that sentence is assuming causality, and I was not really willing to make that particular leap of faith. And on that basis, I was a little bit concerned about the article, so I thought I would do a little bit more reading and educate myself a little bit more on that topic. So one thing that was in that study was that there were far more people that had alcohol use disorder than cannabis disorder. So why he chose to emphasize one of these drugs over the other, you would have to ask him, but certainly he would get better traction with the peer review editors, starting with cannabis. And what is clearly true, and what he showed in a prior study of the same database done maybe 4 years previously, that was that a diagnosis of schizophrenia was positively associated with the risk of developing substance use disorders, increasing cannabis, alcohol, stimulants, and other substances. So even he recognizes the fact that there is a entangled relationship between the use of substances and, in this particular, a very disabling mental illness, which led me to one final paper that looked at the timing of the use of substances and the onset of symptoms of mental illness. And that study showed that about a third of the patients had substance use problems prior to the onset of the diagnosis. About a third had substance use disorder at the time of the diagnosis, and a third developed it subsequent to their diagnosis of mental illness. And I think that really speaks to the bottom line of what's really going on, is that in many cases, cannabis, like alcohol, is used to self-medicate and to help an individual with symptoms that they find particularly bothersome.
So there's a lot to get into here. And I think if I'm hearing you right, I tend to side with you in thinking that this study is pretty limited in what it can tell us.
Yes.
But before we get to that, there's a few things that speak to its support, or at least to its validity as a baseline sort of a study. So let's go through these. I'm curious to get your thoughts. The first is that, and you mentioned this already, is that this isn't your daddy's cannabis or your granddaddy's cannabis, if you will. And I think in Denmark, where this study was performed in 2006, the concentration of THC in the kind of marijuana you could get was like 13%. And
Yes.
Today it's closer to 30%. So we're talking about a massive increase in the psychoactive component of marijuana. And this is the compound that gets you high, if you're not familiar with what we're talking about here. Right. So my first question is, and this is, I guess, a little more general than this specific study, but the argument, or one of the arguments I've heard from drug legalization advocates over the decades, is that one of the reasons to legalize drug use is that you can regulate it and you can have a better sense of what's actually in the drug, and you can control how much of the active ingredient, or the offending substance, if you will. You can control that when the drug's legalized. And maybe there's some truth to that with substances that people would consider hard drugs, like cocaine and methamphetamine and so forth. But with marijuana, it seems that legalizing it, as you said, has created this massive, I guess you could call it a gray market. And the amount of THC that you can get from gummy bears or, from a joint or whatever is much higher. So what do you think's going on there, if you have any thoughts on that?
That's true. And the industry writ large has tried to put in place measures to indicate people what the concentration of THC is in any given product. But inhaling THC, the onset is a lot faster than ingesting THC or putting it under your tongue. So there's some individual variations in there, and of course, despite the fact that the industry wants to regulate itself, there are always bad actors that will publish higher potency levels because that's what sells. And I think the force is just a plain market force of trying to differentiate your product from somebody else's product on the market, and the concentration of THC is an easily manipulated variable in the mix. So I think that that's a significant part of it. And I wouldn't doubt for a minute that higher potency cannabis may give susceptible individuals bad experiences and would be more likely to do it. And I think that that's where we begin to start seeing that people that have whatever constellations of genetics and environmental factors will lead to a dissociation of personality that is schizophrenia. That a drug will maybe be the last piece, the tipping point, to fall in that category. But it's there amongst a constellation of other factors that are involved.
I see. So this, it sounds like, is sort of the headline grabbing variable that everybody wants to talk about. As you alluded to with alcohol, right? That might equally
Yes.
well explain these results. Sounds like genetics has some role to play. It could be childhood trauma. It could be so many things that are influencing this outcome. But everyone's
Yes.
talking about marijuana because of legalization and because of our
Yeah.
liberalized laws.
Right, and because we've already learned that prohibition did not work for alcohol, so that that train has left the station, so to speak. And the other thing that I think that I brought to the article came from my chance to go down to Key West and visit Ernest Hemingway's home down there, and that's what I kind of ended the article talking about. Ernest Hemingway had a significant amount of mental illness in his family. His father committed suicide. He committed suicide. He was admitted to the hospital with depression. He was one of the earliest patients to get ECT. And he was, by all accounts, more than simply a big drinker. He was probably in the range of alcoholism on an objective basis. And this was true when he was in his most productive years. And if you look back on that period of time, he was a bare knuckle fighter for several years and had head injuries from that. He was in 2 plane crashes where he had head injuries and walked away with concussions. So it's very hard for me to tell. And I think the story goes that it very well may have been that part of his drinking was an attempt to deal with the demons that were already living inside of him. And I think that that's equally true today for a subset of people with cannabis.
And that leads me to my next question, because there were a handful of researchers who responded to this study, and they said more or less what you're saying, which is that people with schizophrenia, for one reason or another, are probably inclined to some sort of drug use, to some sort of self-medication. And that's probably what you're seeing here. And the most prominent figure I'm familiar with is Dr. Carl Hart, who, and I'm not terribly familiar with his work. From what I understand, he's a big advocate of drug harm reduction, and even in some cases, recreational use of harder drugs. And this seems to be his perspective, is that, and we see this a lot too with people with other mental illnesses like depression. They will seek out a substance like nicotine for its therapeutic effects.
Yes.
So do you think that's likely what's happening here? Is that people are going to a substance like marijuana to alleviate whatever symptoms they're experiencing?
Yes. Well, I mean, we see it. The people are using legalized medical marijuana in a medicalized way. If you look back at the data on medical marijuana, it's often for chronic pain, which is a real problem, but is difficult to objectively measure. There's certainly a subjective component to it. So I think that marijuana is the latest in the drugs that we allow to use for self-medication. It's over the counter now, much like alcohol, and so that it shouldn't be surprising that as we take a drug and put it out to the wide world, we begin to see its real life consequences. And I think that that's what the study points out, is that once again, there is an entangled relationship between cannabis and schizophrenia, but to say that it causes 15% of schizophrenia, I think is a leap of faith that I'm just not willing to make. I don't think it's anywhere near that level.
So I've spoken to 3 physicians now about this. You're the third, and
third opinion.
Third opinion. Yeah. I'm going to get the answer that I want, one way or another.
That's the whole purpose of these opinions.
Absolutely.
When you want.
That's right. I want what I want. I'm going to find an expert that's going to tell me what I want. No, but in all seriousness, the first 2 physicians were ER doctors. The first is Dr. Ronit Liv, who's done some writing for ACSH. The second was another ER physician named Dr. Liza Dunn. And both of their perspectives more or less seem to be that there is something going on here, but it's probably not schizophrenia. It's something called cannabis-induced psychosis, which is, right, that exists on a spectrum too. It affects people differently. But both of them told me, I would be at the hospital, people would come in and they had consumed more THC than they knew they had, and they were having symptoms of this condition. But they also said, this appears to affect very specific subpopulations of people. It's not that there's a clear, dose-response relationship between how much pot you smoke and your risk of schizophrenia. Would you agree with that?
Yes, I think we're all saying the same thing, that there is a subset of individuals that for whom cannabis use will trigger a mental health break. But it very well may be that there are other psychoactive agents, including the ones that we're all very happy with, i.e. alcohol, that may cause the same problem and that have been causing the same problem for generations.
So let's get into some of the limitations of this paper. So, right, so I just tried to kind of front load everything that says, well, maybe there's something here, but there were some concerning things. So, for example, and you get at this in your title, which is, this is clearly an association, but which came first. So one of the things that stuck out to me is that the authors of this paper, they didn't know how much of the drug people were consuming. It was all self-reported. And as we've talked about ad nauseum on the show, people lie about the amount of drugs, food, alcohol, whatever. They just don't tell you the truth. So how badly does that limit these results, in your opinion?
I think the self-reporting is clearly a part of it, but I think even more importantly is the fact that they only looked at a database of people with cannabis use disorder and schizophrenia. So right away, there's going to be a linkage. The other problem with that linkage is that it's not necessarily unidirectional. I think that that's the bottom line of the story. When I say that which came first, it's because it's hard to say whether the schizophrenia caused the cannabis use disorder or vice versa. And there's no data at all in what they looked at to say which one of the diagnoses was made first. That I had to go look for some other study, and then the study that looked at that showed that about a third, as I said, a third before, a third during, a third after the diagnosis of mental illness was made. So that's why if we're talking about the directionality of it, that's why I like that particular study better, because it got at the question of which one came first.
Right. So it sounds like we just have a long way to go with this kind of research, and maybe there is some legitimacy to that in that the fact that for the longest time, and it still is actually, marijuana is still a Schedule 1 drug,
Yes.
as far as the federal government's concerned, and with state liberalization efforts, it's becoming easier to do this kind of research. But for the longest time, and I've heard other experts say this too, is that it just wasn't possible, or at least it was very frowned upon, and it was hard to get funding for research that would, objectively test the effects of marijuana use. And now that those restraints are starting to come off, you can start to do research like this. So over time, hopefully we'll get better design papers with better data, and we'll get to the bottom of this.
Maybe.
Yeah, it's tough because we've talked about lots of subjects and lots of epidemiological research on this show, and 40 years later we're still talking about certain chemicals that are widely used, and the data is still spotty. So maybe I'm just being too hopeful, Chuck. I don't know.
The hope springs eternal.
Okay. All right. Well, check out Chuck's article, which again is called "Which Came First, the Cannabis or the Schizophrenia?" Good breakdown of this paper and all the technical details. Now let's move on to Dr. Josh Bloom's story. Will Pfizer's new weight loss pill silence the Ozempic commercials? And I love that Josh can take important science and health topics and then pair them with whatever is bothering him at that given point in time. It's pretty impressive. So you don't have to go through all of the details here, but just give people a little rundown. What are these drugs we're talking about? And then maybe briefly, how do they work?
This is a class of drugs that were designed to be used for diabetes. And the thought was that they suppress your appetite. There's some more recent suggestion that it may be suppressing more than appetite, but they suppress your appetite. So for patients with diabetes, it cuts down on the amount of food that they take in. As a result, that helps control their glucose levels. As a side effect of that, there has been a significant and persistent weight loss with the use of those drugs, and people have jumped on the side effect with both feet. So to talk about that, we have to, get back to talking about people being overweight and people dieting, and dieting to lose weight, as I know from bitter experience, is a tough road to go. And it can be done, but it requires far more discipline than I've been able to get on a persistent basis. I can do it for a while, but not forever. And I think that I reflect the majority of people. There have been two breakthroughs in weight loss. The first was bariatric surgery, and bariatric surgery has proven to be far more effective than diet in controlling weight, and for people with diabetes in controlling their diabetes. In the proper hands, surgical intervention to reduce the size of your stomach or reduce your digestive tract is one and done, and it lasts, essentially forever. So that was a big breakthrough. And the pharmaceutical people have been looking for their holy grail in this area too. And this class of drugs turns out to be what they believe to be the answer. Because if you take it on a consistent basis, it has a reasonably good safety profile and will reduce your weight in a significant manner. And so now they have something to offer that's even less minimally invasive than the bariatric surgery. And that's a big reason why these drugs have become particularly popular. So the breakthrough here is that the drugs that are available, Ozempic and its friends, are all injectables. You have to give yourself an injection every week. And what is being touted now is a pill. And in the world of patient compliance, very few people like surgery. More people are willing to take a shot, and even more people are willing to take a pill compared to diet. And that's the bottom line of why this seems to be getting to be a much more popular approach to our weight.
So with both of these drugs, and I'm probably going to mispronounce this, but the new one, Pfizer's new one, is called danuglipron, something like that. Is how you pronounce
that sounds
it?
Close enough to me. I didn't even want to touch the name.
Okay. I don't know which PR firm they pay to come up with these drug names, but they need a new one because these are just.
Well, this is the name that they're going to work with. Then they're going to give you a new name.
Okay. Okay. So this is sort of like the working title of the album, kind of a situation, maybe.
Yes. Yes.
All right. So let's get into the advertising bit. This complicates the issue because you have this clinical data, and both of these drugs, if I'm looking at the numbers correctly, they seem to reduce your weight over a period of maybe 3 to 6 months between like 5 and 10 pounds.
In the short run, it was 4 pounds for the danuglipron,
okay.
and at a longer period for Ozempic, it's 10 to 12 pounds.
Okay.
And they're and remember, Josh is reporting out a phase study, so they don't have their long-term data completely in place. But I would not be surprised that it had very similar numbers, that you can get rid of 10 or 12 pounds easily without doing anything else in your life by using these drugs.
Okay. Yeah. And just to be clear, the study he's looking at here, this is a 16-week clinical trial. Yeah. So yeah, it's not super long term, but it's long enough to have some kind of a result here. So anyways, my concern here, again, as someone who's struggled with my weight over the years and has had to work to keep it at a reasonable level, is that people are going to see these ads and they're going to see families dancing in the backyard and having barbecues, and they're all happy. Even the dogs are happy in the commercials, as one commenter on Josh's article pointed out. But then layered on top of that, you have Hollywood, which is always a good moral compass, really driving the use of these drugs because you have celebrities, you have musicians and movie stars who are taking these to maintain or lose weight, and they're talking about it on Instagram and TikTok.
Yeah.
And that's going to drive the popular culture, right? That's going to drive people that consume all of the media, you know, you and me and our friends. So what's the fallout of that? I mean, presumably some of these people do, for medically necessary reasons need to lose weight, but a lot of people are just like, I don't really like this flat tire I have around my middle. I'm going to, inject myself with this and, just shave off those extra 10 or 12 pounds. Yeah. Well, what do you think about all that?
I think it's true. I think that there is a problem with our weight overall for a number of reasons, and that we've talked about ad nauseum, and that the standard answers from your doctors are not things that we want to hear. Eat well, exercise, I can say that. I say it to myself, and sometimes I manage it, sometimes I don't. It's difficult. So if there's an easier fix, people will take advantage of it. And that's why I said bariatric surgery is an easy fix, but it's an operation. Ozempic and this class of drugs is an easy fix because it's an injection or soon to be a pill. And there's a lot of allure to the easy answer. And I think that's why it's going to get a lot more play. In addition, because we're talking about patients with diabetes, there are additional cardiovascular benefits to these drugs because it controls your blood sugar more closely than people with diabetes have. So I think that all speaks to it. The two pieces, and this really gets down to marketing, is price, because this is $1,000 a week for these drugs if you can get them, and fear of needles. And the fear of needles, I think, is what's going to drive people towards the pill. Though when I just to look it up, I looked up the information on Ozempic, and the Ozempic needle is the smallest needle that is used in medicine. It's the size of 2 human hairs. So there's probably some anticipatory expectation of pain that's really not there when you give yourself an injection with it. But the people that are fearful of needles are going to be very happy to move towards a pill just on the basis of how the medication is consumed. The next question is going to be whether they're going to price that pill at a meaningful number that people can afford. And just to tie it back to something that we've talked about on a lot of occasions in the past, if obesity is a disease, then there's going to be a big push for the insurance companies to cover the cost of these medications as part of your health plan.
That's another messy question, because that is an ongoing debate. And you have a lot of people now pushing for the fact that obesity, it's not a disease, it's an identity. It's a culture in and of itself. And, you shouldn't try to force people to lose weight because you're attacking them as people, right? So that's super messy. I don't know if we can solve that. The other issue that I'm curious about to get your input on as a physician here is that with a lot of medicines, and I think this is true with insulin and other drugs that are used to treat type 2 diabetes, is that they work so well, they allow people to regulate their blood sugar so well that they, in many cases, don't have to regulate their diet, or they don't really have to exercise, and I know a lot of people very close to me who drink way more than they should or eat way more than they should, and they get away with it because they use drugs that can keep their blood sugar within a reasonable limit. So, yes. I it sounds to me, and again, as a non-expert here, that seems troublesome because you're really not fixing the behavior that's putting you at risk. You're just managing the symptoms. Is there a risk for that here too?
I suppose there will be, but it depends on what you're most interested in. If I'm most interested in better hemoglobin A1C levels, better glucose management, and better cardiovascular outcomes, then a pill that lets you cheat, I'm happy with. I can deal with that. I can, the healthful behaviors are meant to get to those outcomes that I wanted. So if I can achieve those outcomes in another way, I'm certainly open to it. And I think diabetes has really undergone a huge shift in the last 10, 15 years in terms of its management. First of all, there's more people being diagnosed with it. Now we have the diagnosis of pre-diabetes, even though many people with pre-diabetes never develop diabetes, but we'll put that to the side. I think that the development of these glucometers that we wear, where you can start to get feedback on how your activity and your diet influences your particular blood sugar, is beginning to have a significant effect. And I think that will grow over time. And if machine learning is looking for a place to do something useful, that might be a good place to start. People are learning how to manage their diabetes without seeing the doctor every 3 or 4 months, and without having to hear, unfortunately, the platitudes that the doctor can give you, which is to eat a healthy diet, exercise, check your blood sugar 3-4 times a day, and make sure it's within a range. Now it's a lot more convenient to check your blood sugar anytime you want, and you can experiment with it. And I think that may make a huge difference in the next few years.
And here's my final question, and maybe this is the other side of the argument, is that a drug like this, since it works by lowering your blood sugar in part, it reduces your appetite. So maybe, if I'm not mistaken here, people who take this under a doctor's supervision are actually going to learn to get better at regulating their appetite, because the drug is going to discourage them, in other words, from eating an entire bag of potato chips, because they won't have that same impulse. Right, at the biochemical level. So is that true?
I think that there's definitely a Skinnerian component. I don't remember the name of that potato chip that they had, but they developed a potato chip that was lower in cholesterol, but it gave you diarrhea. So, you could eat them, but if you ate too many potato chips, you just, you were in the bathroom. And so you learn to regulate your potato chip intake that way. And that very well, I think that's the advantage of glucometers is it makes the target much more available for one to see if one's inclined in that direction. And I think that you're right, that these drugs will cause people to rethink other portions of their diet that make a difference. It's funny, I got to go away for a while, and we were in Paris where my wife had me on forced marches of 10 miles a day on average. So despite the fact that we were eating more, I gained no weight. But what was clear from eating in Paris and eating some just wonderful meals is the portion size in Europe is so much smaller, at least in Paris, than it is here. There's no golden corral in Paris. And, it's things like that. If people can learn that would make a big difference.
Well, and just a final thing, I keep coming up with things to say here as you talk, but it seems that it does take certain cultural factors to drive people to lose weight, and I mean, I don't think I'm really ashamed of this because it doesn't really matter. Is that the motivation for me to lose weight back in the day, and for a lot of people, it's vanity, or it's I want a girlfriend, or I want a boyfriend, or I want to look good in this new outfit, or I want to feel comfortable on the beach or whatever. Or, as you get older, at least for me, it's like, as I have kids, I want to be around to spend time with them, it's good for them. Don't get me wrong, but it's selfish on my part. It's not that I'm looking at all of this peer-reviewed literature and going, well, if I exercise 3 times a week, my body weight's going to decline by a statistically significant, like, nobody cares about that. So, exactly. So maybe none of this matters is what I'm getting at. And I think this was your point, right? Is if people are getting healthier, then who really cares about everything else?
If this is going to lead to more well-controlled diabetes in people with lower weight, go ahead. That's fine, because all the things that we've done have not worked well. So this is something that we can do. I don't think that it'll, I think in 50 years from now, we'll be doing something else, but it's fine. As a physician, I have no problem with saying this is another way to manage your weight.
Yeah, in 50 years, we'll probably be selecting embryos based on their propensity for weight gain, which is another horrifying topic we've yet to explore. So I guess we'll see, Chuck. That's all we can say. I guess the answer to Josh's question.
As usual. We'll see how things go.
It's a science podcast. What do you want? We don't have definite answers here, unfortunately.
I left with that one line from Woody Allen. You'll forgive me choosing Woody. Sleeper. And, he dies and he's in suspended animation and comes back 100 years later and he asks where all his friends are. And they say, well, they're all dead. How can that be? They all were eating brown rice. And I think that's the difficulty with these dietary things. We're going to be saying the same thing in another 25, years. That how could this have happened? Why were we eating this along the way? Don't we know that would have killed us?
Well, I guess the only thing we can say with any certainty is that no, this is not going to kill the Ozempic commercials. You're just going to have more drugs, more stupid commercials, more smiling dogs in the background. And so Josh's TV time is going to be all that much worse.
Yes, he's going to have to choose another channel and stop watching the geriatric network that we're all hooked to.
Hey, Josh, just hit the mute button, buddy. That's all it takes. You just mute the commercials, go make yourself a snack, and then come back when your show's back. That's it. Okay. All right. So one more time, the story is called, Will Pfizer's new weight loss pill silence the Ozempic commercials? The answer is no, but there's some interesting science in here. So go check out the article and read the study. And with that, we'll call it a day. We'll be back next week with episode 44. Until then, you can follow us on social media at ACSH.org. I am at CamJEnglish on Twitter. If you want to ask questions or talk about the show, happy to do that. Chuck's not on social media, so you'll have to tweet at the organization and then we will get that information to Chuck.
Oh, it gets to me, not to worry.
This is true. This is true. If you guys only saw the emails that Chuck has to deal with.
Okay.
All right, folks. That's it. See you next time. Have a good one.
Bye.